So I had started doing iovera back in 2014. At the time, the company was called Myoscience. They came down and asked me to kind of check this out. And you saw the picture of this device. I mean, it looks kind of very dainty. And it was born out of the aesthetics dermatology space. They were actually using it to freeze forehead nerves, motor nerves in the forehead in Europe to try to compete against Botox for wrinkles. And then they pivoted, came to the US and realized, you know what, there may be a huge opportunity, market opportunity to target and freeze nerves around pain. So they came to me back then and they said, you know, what did I think of this? I thought it was interesting, you know, but, you know, an orthopedic surgeon kind of holding a dermatology device didn't really appeal that well. But you know what, the science seemed to make sense. And so what happened was I said, okay, let's go ahead and try this. You know, with most new technologies, at least this is the way I think. I'm going to throw my train wrecks at it and see if this works. And if it does work, then maybe I'll give it the time of day. But if it doesn't, then, you know, take a hike, right? And so I had a number of patients that were total knee patients. They were bone on bone, didn't want surgery or couldn't have surgery for one reason or another. Steroids weren't working, HA injections weren't working. You know, really the only thing I had left was potentially putting them on chronic opiates, which obviously is not the best thing in the world either. And so I had a bunch of these patients where I said, you know what, would you mind trying this new device, this new treatment to see if this works for your knee OA? And the patient said they were game, right? Because they really had no other option. So they said, fine. So the Myoscience, the iovera folks came down and I lined up a few of these patients for my first treatment. So the first patient, I don't know if any of you guys have been in New Orleans and you've ever done a second line. A second line is kind of a celebration of when someone passes away. They've got an umbrella and handkerchiefs and they kind of dance in the street and celebrate. We have jazz band and we celebrate someone after they pass away. So this first patient came in. Again, bone on bone patient. She said she'd be willing to give this a try. She had an umbrella with her. It was raining that day. Puts the umbrella down. She lays down on the table. And at the time back then, we were only treating the ISN, infrapatellar saphenous nerve, not the AFCN. And so I drew out that treatment line, 5 centimeters medial to the patellar tendon. I numbed the skin up, just superficial wheel with lidocaine. And then I went ahead and treated along that ISN line that I created. Now, mind you, this is the first one I've ever done. Didn't know what to expect, even though they told me what to expect. You know, again, until you do it, you don't really appreciate it. So I stick the device in, I turn it on, nothing happens. Okay. So I go to the next spot of the treatment line, turn it on, and then the patient kind of jumps and says, you know, I've got this burning pain, you know, and I'm sweating. I don't know what's going on. And the patient doesn't know what's going on. And, you know, the Myoscience, the iovera person saying, it's okay, it's okay. So we stop, treat the next section. She doesn't feel anything. Treat the next spot. She feels it again. And then I freak out. She freaks out. Everybody's sweating. Then we treat the next spot and it's gone. And so we treat that whole line. I stop. Patient gets up. She grabs her umbrella and starts doing a second line down my hallway. And she's like, Dr. Dasa, I haven't done this in about 5 years. I said, okay, interesting. So I said, all right. So next patient comes in. We lay her down, numb up the skin. I treat. She doesn't feel anything. I treat. She feels something. I jump. Treat. Nothing. Treat again. She feels something. I jump. Treat again. Nothing. She gets up. She starts doing squats in my exam room and says, Dr. Dasa, I haven't done a squat in 5 years. So again, these are bone on bone patients. Third patient comes in with her walker, lay her down, numb up the skin, treat the line. She gets up, grabs her walker, and just leaves. So I'm sitting here thinking to myself, okay, you know, these are patients I've been taking care of for months, if not years. They're not crazy. I'm not crazy, you know, and they just did something that I had not seen ever before with steroids or HAs or anything for that matter. And so I said, all right, this is interesting. So I started doing them on these bone on bone patients because, you know, it seemed to work, and there were these patients that really had no other options. So I started doing them, and I bring them back at around 6 weeks, 4 weeks, 8 weeks, somewhere in there, because I wasn't sure how this would play out. And about 6 weeks-ish, somewhere around there, again, these bone-on-bone patients were telling me their pain starting to come back. But for those 6 weeks, they had tremendous relief. I mean, tremendous benefit. They were like a new person. So I was thinking to myself, all right, in the context of knee OA, just chronic knee OA, 6 weeks of pain relief, despite it being this compelling and significant, is not a big deal, right? but I wanted to leverage these results and figure out how I can use them because they were pretty compelling. I wasn't doing anything inside the knee, no intra-articular injection. You know, in the world of orthopedics, we always think, all right, I have to treat directly whatever the issue is. I can't treat it distally or away from the pathology in order to solve the problem. And here I'm creating this tiny little ice cube, 5 centimeters away from the joint, nowhere near being intra-articular. I'm getting this huge response. And so how do I figure this out? Where do I position this? How do I do this? The other thing is I'd done enough of these to that point where I was comfortable that there was nothing negative or really bad that was going to happen. Just like probably everybody on this call, I was worried about neuropathic pain, permanent nerve injury, hematoma, cellulitis, all the things that we would worry about if you're going to try to target and permanently injure, not permanently, but intentionally injure a nerve. What would be the potential consequences of that down the road? You can read the science all you want, but until you see it clinically, you're not gonna trust it. And so I'd done enough of these over a few months where I realized, all right, the clinical is following the science. I'm not seeing any of this neuropathic pain. I'm not seeing any infections. I'm not seeing any of those adverse events that we were extremely paranoid about. And I was seeing these really compelling results out to 6 weeks, 8 weeks after that treatment. And so I said, you know what? 6 weeks of pain relief, while maybe not impactful or meaningful in the context of knee OA, in the context of surgery, actually, it can be pretty powerful. So I decided to go ahead and try to do this before knee replacement. So I went ahead and just completely flipped the switch and changed my practice and started doing iovera about a week before my total knee replacement. So typically I'll do my total knees on Mondays, and I started doing them the Wednesday before. So about 5 days before, for two reasons. Number one, logistically, that's where it fell in terms of having the time to do that and having the openings in my schedule to do it. Because at that time I was doing it. I didn't have my PA or anyone doing it because I wanted to make sure I was doing it. There was no evidence, there was no nothing. So I wanted to own this. I needed to make sure that this was being done properly. And number two was, if I do it the Wednesday before, I thought, 5 days is enough time where if there was going to be a problem with the treatment, it would declare itself by Monday. So if it was an infection or hematoma or whatever, but again, I'd done enough of these up to that point. I was pretty comfortable that there would be no issues in terms of really acute adverse events or acute problems. And so I went ahead and started doing the treatments the Wednesday before my Monday surgeries. So about a month into this, I was walking the hallway in the hospital, and one of the therapists stopped me and they said, you know what, Dr. Dasa, I don't know what's going on with this iovera thing you're doing, but keep doing it. And I said, what are you talking about? She said, we're achieving the milestones that we typically see at 8 weeks or 6 weeks in only 2 weeks. And the patients have very little pain, and you're making our lives 100 times easier as therapists post-operatively. So I said, okay, interesting. I went up to my office. I saw my MA, and I went to Cynthia and I said, what are you seeing? And she said, oh, we're not getting any more phone calls anymore. I said, what are you talking about? She said, those phone calls that we get 3 days after surgery where they think you're the devil and they wish they never had surgery. We're not getting those phone calls anymore. I said, oh, all right, interesting. So I turned to the residents and the students and I said, all right, how do we get our hands around this? How do we measure this? What do we do? And the residents reminded me, that I've got a very rigid, strict narcotic protocol post-operatively. At the time, it was very strict, but I was very generous. And so at discharge, you got this prescription of oxycodone, no more, no less. At 2-week follow-up, only if you asked, you got this prescription, no more, no less. At 6 weeks, and at 3 months, you were completely cut off. And so it was a fairly rigid protocol. The residents knew exactly what it was. I followed it. And so they said, we can very easily pull my narcotic prescriptions and look and see if we see a difference in those iovera patients compared to the pre-iovera patients. Now, obviously, we collected PROMIS scores and KOOS scores, and we had length of stay and readmission rates and all the typical outcome scores that you would expect to be captured. And so what we did was we basically looked at the first 50 patients after using iovera versus the 50 patients immediately prior to that. and we looked at my narcotic prescriptions and how they changed. So again, these are narcotic prescriptions. This isn't a pill count. This isn't pills taken. This is simply the prescriptions that I was writing for my patients. And we were targeting the ISN and the AFCN. And what did we find is what we found was I was prescribing 45% fewer opiates in the 12 weeks after surgery in my iovera group compared to the non-iovera group. And then what we found was both a clinically and statistically significant reduction or improvement in the pain and function scores. And what we also found was actually so I started doing outpatient total knee replacements back in 2013. And what we found was actually shift to the left. More iovera patients were going home the same day compared to non-iovera patients. And so what we found was a slight reduction in length of stay as well. And I say that because if you look at the paper, it can be a little misleading, or people kind of sometimes interpret it a little differently. I don't want you to think iovera is actually going to take you from a length of stay of 3 days to 0 days. But if you're on the bubble between going home day 3 or day 2 or day 2 or day 1, or trying to go from day 1 to 0 and go to outpatient, this may be one of the technology or solutions that allow you, that kind of tip the scales to allow the patient to go home at that earlier stage.